Hi, I'm Dr. Jack Cush, Executive Editor of RheumNow.com. It is the 3rd of June, and this is the RheumNow Week in Review. This week from the social media feed, we have several interesting reports. Knee osteoarthritis being studied for the association with venous thromboembolism. A large cohort-based study looked at 4,020 patients and matched those at 5-to-1 against over 20,000 controls, both of whom had episodes of venous thromboembolism. And what they found was that there was up to a 40% increase in VTE, venous thromboembolism, in those that were taking non-steroidals, and that was being taken for their osteoarthritis of the knee. An interesting finding has been reported before and is a consideration in many of our patients who have the need for an anti-inflammatory, but yet have a history of venous thromboembolism. Maybe that may further increase the risk and should be a sign of caution. And a review of a cohort of experts who specialize in inflammatory myositis looked at their preferred therapies. In this report, after the use of corticosteroids in high doses, the preferred therapies were, not surprisingly, azathioprine, methotrexate, and mycophenolate. Of course, there's very little evidence in clinical trial data to support the use of any of those. Most recently, there was the Printo study with pediatric JDM, juvenile dermatomyositis, showing that cyclosporin and methotrexate were good and that methotrexate had fewer side effects than cyclosporin. And that both were steroid sparing. But in adults, again, azathioprine and mycophenolate can be added to the list according to the experts. This week, the FDA came up with a new advice and a new rule suggesting that manufacturers of foods and restaurants lower their salt content in processed foods and foods that are cooked for the public. I believe some of the public reports estimated that as much as 60% of Americans eat outpatient meals on a frequent basis. The average salt intake is estimated to be 3.4 grams per day. The FDA suggests that salt intake be lowered and in food and in intake, and that the average daily consumption be reduced to 2.3 grams per day. This follows their recommendations last week of better labeling for the sugar content that's in foods. Obviously, the FDA stepping up in the area of nutrition and trying to improve the American health. A cohort study from the population of those with low back pain looked at the drug use in those with low back pain. Amongst almost 1,500 with low back pain, only 18% were taking chronic medicines. Surprisingly, the ones that they were taking the most of was anxiolytics, which is 14%, non-steroidals 12%, analgesics 7%, muscle relaxants and opioids only 3% or 2% respectively. So this cohort study, based on claims and drug use, showed that actually low back pain tends to be undertreated in patients in the population. A small report of golimumab in its use in acute anterior uveitis showed that golimumab 50 milligrams per month was highly successful in putting patients with anterior uveitis into remission, with 12 out of 15 eyes going into remission, and obviously vision being improved. This is a small study, but nonetheless seemed to be popular in those that were reading the social media feed. And lastly, there's a new infliximab in the EU and Latin America. Samsung has received approval for the marketing of Flixabi, a Remicade biosimilar, for all 6 indications of Remicade in 28 European states, Norway, Iceland, and Liechtenstein, and I guess more to follow. So that's interesting news about the expanded use of biosimilars, especially in Europe. On the news front and blog front, I wrote a blog this week about morning stiffness madness, where I sort of try to dispel the importance of morning stiffness by rheumatologists. stating that it seems to show up in everything, in fibromyalgia, osteoarthritis, inflammatory or not, certainly PMR. Almost all patients have a wide variety of reports of morning stiffness, making it, in my opinion, highly unreliable, maybe with the exception of those who have PMR and GCA, where it's shown to be highly specific. Obviously, the real question is who's asking the question about morning stiffness, and how's the question phrased. Max Hamburger and a few others comment that the way you need to ask that question is, how long does it take for you to get as loose as you normally would, or as good as you normally would during the day, or are you stiff in the morning? What time do you get up in the morning? How many minutes or hours does it take for you to get unstiff in the morning? Those are the ways to ask that question. Nonetheless, I still think there are way better ways of assessing the inflammatory nature of a disease or the severity of a disease with our current tools. There's a report in the New York Times from yesterday, and we put it on the news today, about patient reluctance to take bisphosphonates, that there's been a 50% drop in bisphosphonate prescriptions from 2008 to 2012, and the trend continues. That this is shocking to those who are the osteoporosis mavens, because these drugs are very much needed, especially in high-risk individuals, and that there needs to be better education of doctors and patients on the use of bisphosphonates. Some of the shocking numbers, again, also include that the numbers needed to treat to prevent a fracture is only 50, but the number needed to harm to get an atypical femoral fracture is at least 1 in 40,000, and a lot more for to get an osteonecrosis of the jaw. So again, better vigilance and education is needed in this particular area. There's also a very interesting report from Jeff Curtis and colleagues talking again about gastrointestinal bleed and lower intestinal hemorrhages. They compared claims data, a large number of patients taking tocilizumab, tofacitinib, TNF inhibitors, abatacept, and rituximab, and showed that compared to the other biologics, tofacitinib and tocilizumab had a twofold increase in the risk of GI perforations, and especially lower GI perforations. Jeff and colleagues have previously shown that this risk was mainly seen in those who were older, who had diverticulitis, not diverticulosis, and those who were taking prednisone, especially doses of 7.5 milligrams and above. So the reason why tocilizumab and tofacitinib have this particular small but increased risk, in fact, the number from the package insert with tocilizumab is 0.26 events per 100 patient years. That would be 1 event per 400 patient years. So 400 patients exposed to tocilizumab for 1 year, one would get a GI hemorrhage or GI perforation. But it is a low frequency event. Why those two drugs have a higher rate than the others, not clear. That maybe they are unified in their ability to inhibit IL-6. It may be the selection bias as to who gets those drugs, and there may be as yet unidentified factors. So that's it for the reports from this week. For these citations and references, you can go to the RheumNow website and click on those and read more about these particular issues. Really, the big news this week is EULAR next week. The EULAR meeting, the European League Against Rheumatism, is meeting in London. I'll be there covering the news, getting some videos, getting the interesting news that's happening. Follow us on RheumNow for all that's new and exciting at EULAR. See you next week.